Hypertrophic cardiomyopathy. Etiology, pathophysiology, and pathology. Autosomal dominant. Mutations found in at least 10 genes, all encode contractile proteins, e.g. myosin beta heavy chain and troponin T. Unexplained hypertrophy of the left, and occasionally the right, ventricle, which is usually focal, e.g. asymmetrical septal hypertrophy and apical hypertrophy. Mechanism of hypertrophy unknown, possibly secondary to impaired function of contractile proteins, i.e. a compensatory phenomenon. Degree of hypertrophy variable even between individuals with the same mutation. Left ventricular outflow tract obstruction may occur secondary to septal hypertrophy, Fig 50. Mitral regurgitation may also be a feature, usually as a result of the Venturi effect in the presence of septal hypertrophy, Fig 50. Epidemiology. The prevalence of hypertrophic cardiomyopathy, HCM, is 1 in 500 and it is the most common single-gene cardiac disorder. Clinical presentation. Common. Exertional chest pain. Palpitations. Asymptomatic murmur. Abnormal ECG on screening. Uncommon. Syncope. Rare. Sudden death. Physical signs. There may be no abnormal findings. Common. Jerky pulse. Prominent apical impulse. Systolic murmur at left lower sternal edge or apex. Uncommon. Fourth heart sound, often easier to feel, as a double apical impulse, than here. Investigations. The ECG and echocardiogram must be interpreted together because they provide complementary information. ECG. The ECG is sensitive but not very specific. It varies from T-wave inversion to overt left ventricular hypertrophy, LVH. Echocardiography. Echocardiography is specific but less sensitive than the ECG. Classically, there is asymmetrical septal hypertrophy with systolic anterior motion of the mitral valve leaflet, left ventricular outflow tract obstruction and secondary mitral regurgitation. Alternative patterns include apical, free wall or concentric LVH. Ambulatory monitoring. This is used to identify the cause of palpitations or detect asymptomatic arrhythmia. Exercise ECG. This is used to provoke arrhythmia and assess the BP response, important for prognosis or for vocational driving license. Magnetic resonance imaging. MRI may confirm the diagnosis if echocardiographic images are not clear, Fig 51. NB. It is possible to have HCM without any hypertrophy. The diagnosis may be made on the family history plus an abnormal ECG. Differential diagnosis. Hypertensive cardiac hypertrophy, a concentric pattern of hypertrophy with documented hypertension. Athlete's heart. Differentiation may be difficult because some highly trained athletes, especially weightlifters, rowers, and cyclists, have an identical pattern of physiological hypertrophy. However, this will regress if training is discontinued. A septal thickness greater than 1.6 cm is likely to be pathological. Treatment. No treatment is indicated in asymptomatic patients who do not have significant arrhythmia. Antibiotic prophylaxis is generally recommended for dental and surgical procedures likely to produce a bacteremia. Breathlessness and chest pain can be treated with beta blockers or calcium antagonists, but often these only partially relieve symptoms. Severe breathlessness associated with a left ventricular outflow tract gradient may be treated in a number of non-medical ways. Surgical myectomy, partial excision of the hypertrophied septum relieves gradient, but mortality rate is 1–2% at best. Percutaneous transluminal septal myocardial ablation is a promising new technique. A selected area of the obstructing septum is destroyed by alcohol injected into a carefully chosen septal artery, Fig. 52. Complications. Common. Atrial fibrillation. Always anticoagulate because there is a high risk of thromboembolism. Atrial fibrillation is often poorly tolerated, so consider cardioversion along with antiarrhythmic drugs to maintain sinus rhythm. Note that digoxin is contraindicated if there is a significant left ventricular outflow tract gradient, greater than 5 mmHg, so use a beta blocker or calcium antagonist for rate control. Uncommon. Ventricular tachycardia, VT. Sustained VT is associated with high risk of sudden death and requires an implantable cardioverter defibrillator. Progression to dilated cardiomyopathy, documented in up to 15% of early series, but certainly less common than this in modern practice. Sudden death. Rare. Endocarditis. Prognosis. Risk of premature death is associated with the following: cardiac arrest or sustained VT, syncope, especially when recurrent or associated with exertion, strong family history of sudden early death, diagnosis of HCM in childhood, VT on 24-hour ECG monitoring, BP drop on exercise, presence of certain high-risk mutations, extreme LVH, greater than 3 cm. Disease associations: Friedreich's ataxia and Wolff-Parkinson-White syndrome. NB. Important information for patients. It is an inherited condition. There is a 50% chance of transmission to their children. It is benign in most cases, so reassure that it is low risk if appropriate. Continue as far as possible with a normal life, but avoid competitive physical sports. Seek medical advice in the event of palpitations, dizziness, or blackouts. Carefully discuss before you begin screening. No treatment is indicated in the absence of symptoms, and knowledge of the diagnosis will adversely affect life insurance, mortgages, etc. Occupational aspects. Patients should not be professionals in sports requiring vigorous physical exertion. They may still hold vocational driving licenses if they meet the DVLA, Driver and Vehicle Licensing Agency, criteria.